I must thank the organizers, not only for the wonderful hospitality, but the superb organization that has been very evident during this conference. There has been considerable interest in the UMS CBSQ General Surgery exam, and this is the reason why I'm talking about it, especially to stress the extra European outreach, whether this is just utopic or reality. Some questions come naturally. Where is a European specialty exam applicable? Is it applicable to small states like Luxembourg, Cyprus, Malta, or even Belgium, or to larger states? Why an extra European outreach in this context? If we look at the world map, then you will immediately notice that the so-called big states are not so relatively big after all. Even Europe as a whole, compared with Asia, looks tiny. Also, if we define a continent as a land mass, which is separated from other land masses by an ocean mass, then it is a bit debatable whether we can call Europe as a continent at all. Is there a need for a European exit exam? I think big states need it because of the directive on professional mobility by the EU, problems could arise. And one needs assurance of standards for the sake of patient safety. The small states need it to have a critical mass, to have quality assurance, and to assure equity. And we are not here talking about a particular specialty, we are talking about all specialties. Now, if this is applicable to all states and all specialties, then we shall really have an extended harmonized area for postgraduate medical specialist training. And this would be in the interest of harmonization, quality assurance and improvement, maintenance of standards, equity, professional mobility with safeguards, and patient safety. Some statistics. 15% of European specialists come from outside the EU. The cost of training a general surgeon is about $250,000. But if one calculates what is spent from kindergarten onwards, more globally, it is much more. There is a rising median age of general surgery surgeons in Europe and in the US. At the moment, it's in the urban areas, it's 48 years, and in the rural areas, the mean is 53 years. That is worrying. The growth in number of specialists in general surgery is much less than the population growth. What are the effects of these? If we look at the workforce trends that we have been describing and the rising demands despite decreasing trauma in Europe, it's pointing clearly to a crisis. So, what is an exit exam in general? And what is our exit exam? It leads to eligibility for CCST, but not an automatic conferment, having completed the training program and satisfied all the requirements of the relevant curriculum. It provides supporting evidence for specialist registration. It leads to eligibility for independent practice subject to authorization by relevant bodies. The UMS EBSQ general surgery leading to FABS is a quality mark for training in general surgery. Passing this exam does not give the right to practice in any UMS member country. This is clearly written in the Glasgow Declaration, Appendix 1.3. Such a right is only granted by the relevant national authority. And the Glasgow Declaration was put forward by CHESMA in 2007, so it's been there for quite a few years. Why general surgery at all? It is necessary for pigeonholing, more comprehensive treatment and continuity, staffing of district general hospitals, hospitals in small island states and small islands off the coast of larger states, training surgeons for service in third world countries, dealing with emergency surgery, and training emergency surgeons where this specialty has taken root. So general surgery is not dead. Speaking about the UMS, the BSQ General Surgery exam, the fellow of the European Board of Surgery should be considered on par with the UK Intercollegiate, FRCS, FACS, etc. The role of the UMS, the BSQ General Surgery examination, is to be considered as complementary to the national examinations where these exist. Countries which do not have their own national examination are encouraged to adopt this exam as their exit exam for specialist registration in general surgery. Candidates who pass this exam are awarded the title of Fellow of the European Board of Surgery, FEBS, and receive the corresponding certificate. Candidates must be medical graduates who are either certified specialties or in their final year of specialist training in a UMS recognized specialist training center. Candidates of any nationality are eligible. The published curriculum and eligibility criteria are obtainable from the UMS section and board website. One needs to make some clarifications because this is where the queries come about. Certification of completion of training, CCT or CCST, is not awarded to trainees homogeneously in all EU states or in all countries. Some countries require that the candidate passes an exit exam before even applying for a CCT. Others confer it to those who pass a national exam. Others still to those who pass a local exam. And there are still many countries who confer CCT or equivalent without any exam whatsoever. So there is no homogeneous way of conferring this. It is necessary to have a competent authority which confers CCT. For example, the Specialist Accreditation Committee in some countries, the General Medical Council in UK. The other query that often comes up is the one of recognition. This is actually a very relative term. Though the EU directive on free movement of professionals is in place, it is the national competent authorities which decide. Competent authorities such as GMC, SAC, ECFMG, etc. National legislation for automatic recognition is required. And this can be done either through unilateral or bilateral agreements. A national framework for qualifications and levels is necessary. Comparability statements for qualifications, for example, a directory for equivalence, is also necessary. This has to be developed. Occasionally, one has to resort to precedents, legal precedents. Just as an example, there was a vascular surgeon coming from the continent, working in UK, whose qualification, UMS qualification, was challenged. The case went to court, and the court decided that there was complete equivalence between the FRCS and the UMS BSQ qualification that he had. In my opinion, the best option for the EU to clear all these problems is to merge the postgraduate medical training with the modified Bologna process. But this is unlikely to happen because the third cycle of the Bologna process is having a lot of birth pains. What is the content of the exam? As usual, knowledge, skills, and attitudes, professionalism, that is. In the evaluation, one tries to be as objective as possible. One has MCQs, OSCEs. One could also have objective structured assessment of technical skills or global operative assessment of laparoscopic skills. But at some point, there will be a subjective element. Even numbers on a Likert scale at the end of a rotation, despite their being numerical, are actually subjective. Narratives are obviously subjective. However, there's need for evaluation. First of all, to remedy deficiencies, but also because of the impact it has on patient safety. What assessment prerequisites are necessary? Appropriateness and relevance, standardization, validity, reliability, objectivity, transparency, and equity. One cannot take one aspect of this in isolation. One has to take them globally, as this cartoon tries to portray. What we strive to achieve are clear exam regulations, sufficient resources to support assessments, compliance with legislation, data protection, and equal opportunities, quality assurance, potential for quality improvement, consistency of approach across and within various specialties, and review and appeals procedures. What is important that the eligibility criteria are clear and unequivocal, that the curriculum is competence-based rather than number-based, and that the syllabus has flexibility, and the reasons are that there are diverse emphasis in the various syllabi that are produced from the different states. And when you try to get these together for a European syllabus, one encompasses everything, but one cannot expect each candidate to be highly proficient to that extent in all these various points of emphasis. Quality assurance. This must be both internal and external. There is a body, CESMA, where they are extremely competent in doing this external assessment. Visitation and certification of training centers is also necessary because it's not logical to assess the product and not the machinery that produces it. There is a body called NASCE that is really concerned with skill centers, but in my opinion should widen their scope to the whole spectrum of postgraduate medical training. A competence assessment form which is widely used and is accepted by all would be a great help. It is usually 4 sections, each of which involves several elements, such as overall professional capability in patient care, knowledge and judgment, quality of response, bedside manners, and related aspects. The assessment pathway is cyclical. So you plan the assessment, you do it, you judge the evidence, you review the progress, and then from what you learn from this review, you plan the next assessment. There are problems, of course. There are technical problems such as language, diverse emphasis and attitudes that we have spoken about. There are political problems such as Euroscepticism, neo-nationalism, defeatist attitudes, and the determination of local authorities to retain total control of career structures, advancement, and allocation of posts. This is a real problem. There are also solutions. Language problem, well, I think the clearest way of doing it is to have a lingua franca. At the moment, the best candidate for a lingua franca is English, but it's not said it will be always so. It could be Chinese in decades to come. You can have a lingua franca with an escape clause that is mainly English, but with the possibility to use another language providing translators for the benefit of examiners and quality controllers. I must say I have a few misgivings about this, not because it doesn't work, but one cannot really be completely 100% sure that a translator who must be technical to translate technical language and mostly is local wouldn't be answering himself. In other words, whether the answer would be coming from the candidate or from the translator, and that is a worry. However, I must say that the other alternative, any language with translators, has been adopted by the section of anesthesiology, and they're extremely happy with it and doing very well. One could leave it to the sections to decide, which is one way of passing the buck. Diverse emphasis and attitudes could be countered, as we have already said, by the correct degree of flexibility in competence-based assessments. There are proposed developments, such as a European-based validated e-learning and e-assessment program, a central electronic collection and evaluation of continuous assessment results with feedback, an e-portfolio that is, which is going to be put in place soon, I hope. The thorny question of revalidation and adequate and transparent funding. Pan-European professional improvement depends on innovation, but also on participation of member states. That is, there must be the political will to do this. There are future stages that one can think about, and if one has vision, must dream in this way. The first stage is establishing and consolidating exit exams in all specialties. This has been done. Second step, all national authorities to recognize the European postgraduate qualification. This has been done, but only in part. All national authorities to abandon their national exit exam in favor of a European one. This has been done only by a handful of states. And fourth is converging with the Bologna process, 3 cycles, with the development of a separate rail in the 3rd cycle, that is the one leading to a doctorate, adapted for the longer period of postgraduate medical training. Now, when we say this, one must specify. The first cycle is 3 years leading to a bachelor's degree in medical sciences, and it's undergraduate. Second cycle, 2 to 3 years leading to a master's degree, graduation as a doctor. The third cycle is 3 years leading to a doctorate, postgraduate, a PhD, but here we would like to graft the European postgraduate medical training program, which would be a much longer process, and this would lead to a European Specialty Board qualification. If we do this, it would lead to a real extra-European higher education area, which it would be most commendable. Can we do this? I think we can. With vision, goodwill, and expertise, DOMS and DSS have got the resources to put this in practice.
Mark of a good surgeon is when he can finish the operation in time. Very good.
No, it is a global thing. All nationalities can apply, and it has always been like that. I mean, the UMS and the ESS have always opened up to countries which were not EU states. But now we're going even further, as you heard from Professor Terzi. Our next Congress will be in China and Beijing, and hopefully there'll be an exam there. So there you are.
Thank you.
Thank you.